Thank you very much, everyone, for dialing in, for chilling out with us PD pods. You've all obviously got a little bit of PD pod in you, some of you a bit more than others. So anyway, so this is what we're going to discuss. Let me just work out the tech. So my disclaimer, I am by no means an expert in child protection issues. Okay, I don't want to be one. It's a difficult area. However, the reality check is if you deal with pediatric fractures, you will see non-accidental injury and child protection issues. And the main reason we all want to stay away from it, it is highly emotive, the stakes are high, but you can play a significant part in the pathway of these children, and you are that child's advocate. So listen for the next 12 to 13 minutes. What you cannot do is you cannot bury your head in the sand. You cannot ignore the signs in front of you. And the other thing I've learned is you cannot wear high heels in work. So the spectrum of child maltreatment is quite wide. And what we will see in our practice is the physical element of it, is those children presenting with fractures. And most children, up to 50% of children who are maltreated will present with a fracture. However, you do have to have an understanding of the spectrum of the condition because there will be signs of additional elements of the maltreatment. And again, many of them will have multiple elements visible to them. So some factoids: 1 in 14 children are physically abused, with disabled children and looked after children, so those in care, undergoing adoption processes, etc., at a significantly higher risk. 90% of non-accidental injury occurs in under 5s, with 40% under 1s. For those children presenting to your centre with a fracture and they are under 18 months old, the risk of non-accidental injury is significant. You know, sometimes we're asked, oh, could this be osteogenesis imperfecta? The chance of that is extremely low, and without any further clinical signs of osteogenesis imperfecta or a family history, your chance quoted within the literature is 1 in 3 million. So you have to have a high index of suspicion that this is non-accidental injury until proven otherwise. And on average, at least 1 child is killed per week in the UK, and up to 50% of them have been seen by someone in healthcare within that previous month. And these are quite high-profile cases, historical cases of child protection. Victoria Climby on the left and baby P on the right. And these children had multiple fractures, with Victoria having over 120 injuries to her little body, baby P having over 50 injuries sustained within a long period of time. So these children are not coming in with a single fracture. They have clues all over their bodies. And keeping children safe is everybody's responsibility. It is written in law. We are bound by standards, and all the devolved nations have similar principles. Your hospital, your unit, your healthcare provider will have a lead for safeguarding. And if you have any input with children, it is a mandatory requirement that you get safeguarding training, be it to level 2 or level 3, depending on your level of responsibility. So you have a duty of care to these children. So fractures historically have been recognized to be the only sign sometimes of inflicted injury since CAFE back in 1946. And you, as healthcare providers and as orthopaedic surgeons, see multiple fractures every week. So actually, what raises suspicion in that particular child that may be inflicted injury and not accidental? And that is a difficult call. And actually, it's a call you do not have to make on your own. You are a small piece in the big jigsaw. You are a small part to play, and it is a multi-agency approach to completing the picture and making the decision. So you do not have to worry about the can of worms you may be opening, how you're inconveniencing people or the parents. You are that child's advocate, and you must do what is right. And this highlights to me the difficulty of the bigger picture, because what you see are snapshots in that child's life, and you have to make judgment calls on that. And this is a stepdad, desperately trying to resuscitate his stepchild as he's coming into an emergency department. But what you don't realize is he's actually the perpetrator of her multiple injuries that led to her death. And it's putting the additional pieces together within that jigsaw that made the big picture clear, and ultimately made the conclusive diagnosis of child protection or inflicted injury. So we're all taught there are a number of features that raise suspicion. And again, it's worth reminding yourself what they are. And again, it's significant injury without an explanation. It's a delay in presenting to a healthcare provider. Injury not in keeping with history or the motor development of that child. And we've all had cases where we've been told the 4-month-old baby has rolled off the changing table or rolled off the bed. And we all know that 4-month-old babies don't do that. So it is not in keeping with the mechanism of injury that you've been told. Infants fairly rarely cause significant injury to by themselves. Children do undergo periods of motor development that are slightly different from their peers, so some will be a little bit more advanced. And last week we had a toddler who climbed up a loft ladder and fell down, and we had to instigate the child protection process. And he did actually climb up the loft ladder and fell down. But again, we did no harm by instigating those safeguarding procedures. Changing stories between parents, between nurses, nannies, etc., is always highlights a potential risk. Parental attitude, both to yourself as a clinician and also to the children, can also be an indicator, and that needs to be documented within the child's notes. Is the child on the child protection register, and do they get repeated attendances to ED? We all know that there are multiple external factors that you never know about when you meet that child. And again, during lockdown, all these factors have been condensed and heightened. But again, there are processes and pathways, and there are people around you that can help delve into that information that is held locally within child protection databases. So what is our recognised pathway? Well, usually a child will present to your emergency department with a fracture. And luckily for us, our emergency department colleagues are really clued up on safeguarding policy. And so usually they will do all the background work for you. They look at the history of the injury, they look at the pattern of the fracture, they look then, if there are any safeguarding concerns, they will look to whatever database is available to them. And again, each locality will have different available database, but there will be a well-structured safeguarding pathway. And if the fracture, and if there are significant concerns that go above the threshold, that child will then be admitted to the hospital, and the safeguarding investigations will be instituted by your safeguarding team. So that's easy, that's the easy call for us, because then the child gets transferred into the safeguarding team, and they will look after that aspect of safeguarding care. And then we're left to get on to do the bit that we enjoy, which is treat the fracture. It's interesting to know what the safeguarding investigative process is. It does include a skeletal survey, CT scanning, and we can talk about that later if you want, ophthalmology review, blood tests, and medical photography. And again, as a clinician and a holistic practitioner, you're not just looking at the bone. You do have to appreciate there is a spectrum of inflicted physical injury. Now, you may not have the skills or be required to do the full examination, and there are trained medical practitioners in order to do that, but you need to be fairly holistic and extensive in your assessment. So you need to know that you need to look for bruising and other signs of physical inflicted injury. And luckily for me, Cardiff University have got a fairly active child protection department. They've written a Cochrane systematic review, and this is on the Royal College of Paediatrics website. It's a follow-on from the previous Cochrane review, and it's a systematic review on all fractures in physical abuse. And the recurring themes, the important aspects of abuse-related fractures are this. They occur mainly in under 18 months old. The presence of multiple fractures in the absence of significant traumatic injury, so that's been involved, an RTA, etc. If there's evidence of multiple fractures, no matter what the pattern of injury, that should heighten you that this is a child protection issue. Rib fractures, we all know that posterior rib fractures are particularly specific for non-accidental injury. However, rib fractures in any location should worry you. Femoral midshaft fractures in under 1-year-olds, spiral or oblique humeral shaft fractures, again in the younger child. In the older child who may be a little bit more active, it can occur. And again, the other specific fracture pattern are these classic metaphyseal lesions, particularly in the lower limbs. And again, as paediatric orthopaedic surgeons, if we see these patterns of injury, femoral shaft fracture, spiral humeral fracture, or metaphyseal fractures, this is a no-brainer. I do not have to think about this anymore. I can go into reflex mode. This is a child protection problem until otherwise diagnosed. And these classical metaphyseal lesions can be very subtle. They occur in vulnerable areas of the immature skeleton, at the chondro-osseous junction, and I think most of you have had or seen the case on the website of a transphyseal distal humeral fracture. That is a classical fracture seen in non-accidental injury. The more subtle fractures are these classic metaphyseal lesions, bucket handle fractures, or corner fractures. Those are all the same thing. It just depends on how the radiographic projection is that defines the shape of those metaphyseal fractures. And they all occur due to similar reason, a torsional or a tractional force applied across the metaphysis, and then that fracture is propagated along the path of least resistance. And as with other classical fractures that we're aware of, Salter-Harris, Skiffy, they propagate through the zone of provisional calcification. And these classical metaphyseal lesions are pathognomonic. They are specific for non-accidental injury. There are a number of, we do see them in a number of other conditions, but this needs to initiate your child protection protocol without question. When they looked in the literature at why these occurred in confirmed perpetrators of abuse, these injuries are caused by parents, usually parents or step-parents, holding on to the limbs and forcing them into positions, bending the knees up, grabbing the ankles, okay? The other thing that's a useful tool for us as paediatric orthopaedic surgeons is the bone. The bone only does one of two things. It either produces bone or takes away bone. And in response to injury and that subperiosteal hematoma collection, the bone then subsequently ossifies that hematoma in an organized fashion. And again, depending on the age of the child, if you repeat an X-ray in a child who's had a query traumatic injury, then between 5 to 14 days later, that bone will have produced a reaction to that injury. And again, in neonates, in the younger age group, that may happen at 4 to 5 days. In the older child, that may take a bit longer, of 10 to 14 days. So repeating either an X-ray or the skeletal survey may give you an indication of inflicted injury. But again, it's not specific. We see subperiosteal bone formation in response to bone trauma in a number of conditions, including infection, some metabolic conditions. And again, it is known to exist as a normal physiological phenomena in neonates and up to the age of 5 months. So the reality check for me was that not every child with non-accidental injury comes with a pathognomonic fracture. And when we looked at our cohort of children who subsequently went on to have proven non-accidental injury, unfortunately, they can come with any fracture pattern. So you have to use all the clues around you and not just the fracture pattern. So once you instigate the child protection pathway, these are the recommendations for the radiological investigation. The child will have a skeletal survey under the age of 2. It's then case by case above the age of 2. And again, the child protection team will do bloods or CTs depending on if they feel it's indicated. And at 11 to 14 days, that skeletal survey may be repeated. And again, sometimes that may be in your trauma clinic, and you may have to review that to give a view on the fracture. However, remember, you are not a radiology opinion, and you are not an expert on fracture forensics in non-accidental injury. And actually, there is a national standard that 2 trained radiologists need to report the skeletal survey. So you can always phone a friend. And this is what a skeletal survey looks like. And the reason they do it is that there will be occult fractures in 20 to 30%. One of, I suppose, the controversies of doing a skeletal survey is the radiation exposure. It is equivalent to a CT head with a lifetime leukemic risk of about 1 in 10,000. So it is justified in the investigation of these children, and it should not put you off to put these children down the child protection pathway. High specificity findings we've seen. Again, everything else take its appearance in moderation. The thing that catches us out sometimes there are the great fracture mimickers, bone biochemistry, your metabolic bone team, your pediatric team can help you with that. There are some other plausible traumatic conditions that we've seen: obstetric trauma, novel CPR, hoisting transfers of children with neurodisability. We've got gentle physiotherapists, but again, sometimes we have seen osteopenic fractures in some children. And again, it is reported in respiratory physio and Talaby's treatment. So reality check ahead. Your children with query non-accidental injury don't all come packaged through the front door of your emergency department. And again, safeguarding comes into every aspect of what we deliver as a service. And actually, you have to be mindful of that, because you may have to instigate the whole safeguarding checks if they present by any other route. So I'm going to finish off with a case, to me, that really highlighted the difficulty of dealing with this problem. And this was a young dad who came with his 11-month-old toddling daughter. She was a looked after child and was undergoing the adoption process, and they already had an adopted child within the family. He had said that she was pushing a walker along the living room. She kind of knelt back, twisted her leg, and then subsequently was limping for 24 to 48 hours before he took him to the GP. The GP rang up our fracture clinic, as they do, and said, I've got a child who's limping, will you see them? And of course, we saw them that morning. And luckily for us, we had a very experienced trainee that saw the child, undressed the child completely, did a top-to-toe examination, and examined and documented her thorax, abdomen, upper limbs, lower limbs. There was no bony tenderness. There was no signs of any external injury. She was limping on the right side, so he got an X-ray, and he noted within the clinic note that she had a fracture to her distal tibia. He put her in a plaster, brought her back 3 weeks later, took her out, examined her. She was absolutely fine, walking around the clinic, and was discharged. 5 months later, she comes back in via ED with a catastrophic head injury and dies. And a serious case review into her case, and obviously a post-mortem examination, and then subsequent radiological review, highlighted at the time of her coming to our trauma clinic, she didn't have a single level fracture. She actually had multiple fractures, which on reflection was suggestive of a high impact force and probable for quite severe safeguarding issues. And again, we ended up headline news in a local newspaper, with chances missed by the healthcare provision may have saved the murdered baby. And again, it was a really difficult case for us because those fractures looked fairly innocuous, but they were multi-level. And it should highlight to you that even in the presence of multiple fractures that look innocuous, you should probably ask yourself, is this a safeguarding issue? I also want you to take away, what do you do to protect yourself and your junior staff within your vulnerable areas? So within your elective clinic, your school clinics, and your trauma clinic, to actually pick up safeguarding issues. And we've got some prompts. We are starting pink stickers to highlight, have you considered safeguarding under the age of 5? And again, all our under 2s are discussed at an ED safeguarding meeting on a monthly basis. So they're again, an additional safety net now for us. So if I could say to you, have an awareness that the problem does exist. Recognize the injury patterns that should alert you straight away, but also be mindful those injury patterns very, very regularly help you actually come to that decision to instigate safeguarding processes. Raise the concerns. Don't be worried about raising those concerns, and really understand your safeguarding processes in your unit. Thank you very much.
All right, thank you very much, Claire. That was a really interesting talk. And I think there's a lot of food for thought for lots of us, even those of us who might think they know about this stuff. Can I ask all the speakers to turn on their cameras, and if we stop screen share? Brilliant. Right, guys, we've got a couple of questions here. So one, Claire, I'm going to aim at you, but it says, thank you, Dr. Carpenter. Do skeletal surveys identify additional fractures in 30% of all pediatric trauma presentations, or in 30% of confirmed NAI cases?
In confirmed NAI cases. We don't do skeletal surveys in all trauma.
Right, okay. And that's the thing, isn't it? That's what you've got to be aware of, is which cases need that. And that's going to come down to your history and your arc mnemonic that you're talking about.
Yeah.
And then, guys, I'm going to throw this open to all of you because it's relevant to everyone. Pran, I know you've done some work on this with an interview, but Neil Kang, shoulder surgeon extraordinaire from Addenbrooke's, has asked, he said, thanks for a reassuring and helpful talk for an on-call orthopod like me, Claire. COVID-19 has seen many trends. In your experience and knowledge, have you witnessed any changes in the frequency of NAI over the last year of lockdowns? So open to all of you.
I'll start off. I think on the whole, our general activity has gone down 50%. I think the pattern of child maltreatment has changed slightly. We haven't really seen an increase in fracture presenting NAI, I'll be honest, because on average we see about 6 per year that go on to confirmed non-accidental injury. There are different areas of child maltreatment, neglect, emotional abuse, sexual abuse that is coming through. It is not relevant to us. So for me, my worry is the last slide, which is the warning, which is what is going to be the fallout when we're all let out of our lockdown.
So I think that statistic that Claire said at the beginning is almost the most worrying. So the fact that 50% fewer NAI referrals during lockdown, do we really think there's half the kids being abused in the country at the moment, or is it just not being picked up because these kids aren't at school, they aren't going to the doctors, it's just not being seen?
Yeah, and if you speak to safeguarding nurses, you'll find, especially in the community, they're actually busier than they've ever been. But from a fracture presentation point of view, we've seen less.
Yeah. I mean, I think it's a statistic, isn't it? Domestic violence has gone up. I know a magistrate was saying they've been hearing many more cases, and some of it is really dramatic, the things that can actually instigate the violence and the issues. Right, we've got a talk from Bill Martin, who I believe is from Broomfield. And he said, great talk, Claire, thank you. Virtual fracture clinics mean less opportunity to see the kid. Any concerns or advice here? I've got my own thoughts, but I'll let you guys answer that first.
I've got very strong views about virtual fracture clinic, and it does not happen for children in our centre. Full stop.
That's pretty clear. And I'm going to go the polar opposite view. Okay, so we do virtual fracture clinics for children. All of these kids have been seen by A&E, referred to paediatrics if necessary. But what I'd say the difference is it's a consultant paediatric orthopaedic surgeon looking at these x-rays and the A&E notes, which I would suggest is maybe better than an orthopedic reg in the middle of a busy clinic, just flicking through x-rays and saying, oh, that's nothing, that can go. But I think it's about having that radar and actually looking for it. So on our spreadsheet, we have a column, concern about NAI question mark, and you have to put yes or no. So I think it's how you set it up, and it's going to be different for everyone. But I love your pink sticker idea, actually. So if you're doing things in clinic, that's a great way of flagging up. And I guess maybe you could put it on folders for certain age groups where the person, whether it's a registrar or a specialist nurse, they've got to sign to say, yes, we thought about this. What about you guys? Pranay, Steve?
So we don't, I work with Bill, obviously, and it's just me there. So I don't review every pediatric orthopedic injury. But what we do is we have a very open relationship with the other consultants. So if they have a concern, then we bring them in. And if they're reviewed and they have a concern, I will then see them as the pediatric orthopod on site. And we have obviously the setup for safeguarding with a clinical nurse specialist if necessary.
Yeah.
So we don't run virtual fracture clinics for kids either, but we have tried, certainly during lockdown, hopefully it will continue, it's better sort of early senior decision making in CED. So rather than the sort of standard practice, kid with fracture sent home, come to the next fracture clinic, not just for NAI cases, but any cases. So we try and get the appropriate definitive management early. And if they're seen by someone senior who can exclude or include the NAI question, then I'm fairly happy for them not to necessarily be seen physically in a fracture clinic. But I'm a bit like Claire. I'm not overly fond of a virtual clinic service for children, but early senior decision making, I think, is a good thing.
Right. Last question, and then we better move on. But this is a really important topic. Should I suspect NAI in an adolescent presenting 24 hours post ankle twisting injury with X-ray showing distal tibial shaft fracture, which would be suggestive of higher level of energy injury?
I think I'll start with that. I think if you think this child is 14, you think they may have been intoxicated, they may have been under the influence of something else, and that they've presented late, and there's no way that they would have presented this way other than being under the influence, then yes, I think you've got a duty to raise your concerns, because raising child protection concerns about a younger child, about neglect, about adolescents who may be off doing crazy things is not punitive. This is to help and to care for these children. And we've had, interestingly, via our major trauma centre now, we've had a number of issues we've never had before, unrestrained teenagers in a car with older men. All these are children below the age of 18 have a duty of care to be protected in whatever way. And you may not need the full child protection pathway and investigation, but somebody can help you investigate that child's history. So I would say, yes, you do have a duty of care to look into that.
Yeah, I think you're supporting the family as well as the child, aren't you? This might be a family that's struggling, and identifying that is really, really important. Mm-hmm. So that's a really good question. Guys, would you want to add anything? In fact, I'm going to move on to a different question, because having said that's the last question, this one I think is really interesting. Do you think pulled elbow can represent NAI?
I think one of the problems with pulled elbow is it's so common that it would be very hard on a single event. I mean, things like bilateral pulled elbow, examination showing bruises in, that kind of thing maybe. But I think a single pulled elbow, it wouldn't raise a red flag for me unless there was something else more suggestive.
Recurrent pulled elbow in a child should be reviewed by a paediatric orthopedic surgeon. I think that's sensible if it's a recurrent problem, as opposed to a one-off where it's been managed in A&E.
And I'm going to say, if you're being scientific and looking at the specificity, which is what I suppose the literature will tell you, I agree with the reviews, and I agree with it's not a single event at a single point in time. But if you're being honest, I'd probably say no.
Yeah, I was going to say, it's difficult, isn't it? Because the mechanism is in itself, it's something where a parent is dragging someone by their arm. And I've seen a few kids with recurrent pulled elbows. But again, it's just having that kind of radar and looking out for this stuff. Right, last question. I think this is a really tough one. So this is Daphne Chu, I think he's a medical student. Thank you for the very useful talk. Do you have any thoughts on sports-related abusive injuries in child athletes, especially given the recent highlighting of abuse in British gymnastics? I think this is a can of worms.
Okay. Yeah, so I think the pressure associated with high-level sport can sometimes tantamount on maltreatment. And this is really, really difficult area, because obviously we, as paediatric orthopedic surgeons, see a wide spectrum of MSK-related sequelae of sport and training, but when does that become maltreatment? And so that is a really, really difficult thing. Almost when they get physical signs, you're stepping over the threshold where you can honestly say as an orthopod, well, actually, you know, you may be training at this level, but your body and your bones are unable to withstand the forces going across it. And we classically see that in the gymnast wrists, you know, we see it in a pitcher's elbow, etc., etc. The difficulty for me sometimes is when children then come in with factitious illness, you know, pains, this, that, and the other, and there's almost a psychological maltreatment of them because of the requirement to achieve at high level sport, and that is the difficulty. So I think it probably does play a part, but again, it's the similar story. You are a snapshot and a single piece in the bigger picture, and you've always got friends to call on to help you make that final decision.